I'm going to launch straight into Grant, and he's going to talk firstly about acute scaphoids and then scaphoid non-unions.
We're coming to the end, slowly but surely. All right, I'm talking about acute scaphoid fractures. I'm just going to say thank you to Andrew for this talk. After swinging me a curveball to do this lecture, he said, but I do have a talk that you can use. It was a week ago. So, how does this thing work? There you go. All right, so the beautiful bone. I'm not so sure. We know that the Greeks described it as a boat. I'm not sure. It's more like a twisted, flattened bean in some views, which makes the scaphoid such a difficult thing to treat. It is the most common bone treated fractured in the carpal bones, 60 to sort of almost 80%, but it only makes up 2% of all fractures. And we know that the union rate is 90 to 95% with non-operative treatment. So, what's the problem? Why all the fuss? But there are a few things that make it particularly problematic. Firstly, it's often a missed injury, so it's difficult to diagnose. We know how important this little bone is in the kinematics of the wrist as a whole, so it's actually a fracture of a large joint. And it gives a lot of problems if it isn't treated properly. There's inherent instability and many feared complications. So basically, we're just going to look at a few things: the anatomy, mechanism of injury, some diagnosis, how do we make the diagnosis. Classifications, as with the previous talk, classifications are not always helpful, and then some treatment guidelines and some complications. So, three-dimensional complex geometry. It really makes it hard to fix. You don't know what you're looking at. You don't know which angle to is the most important, and it's just difficult to visualize where the bone is in the wrist, because you are usually not looking at the whole bone. You're only looking at the proximal, the distal end. The blood supply, we know, enters distally and goes proximally from the tuberosity and the dorsal ridge. And this means that the fracture healing is via the endosteal vessels. There's nothing on the outside. There's the blood supply. The other thing about the blood supply is how it affects our approach. The tuberosity supply is right where we drill our screw for the volar approach, and the dorsal ridge is a little bit further away, so it makes your dorsal approach a little bit safer, perhaps. Mechanism of injury is described: wrist extension over 95 degrees, pushing that scaphoid up against the dorsal ridge of the distal radius, and slight radial deviation, the so-called fall on the outstretched hand. So, how do we make our diagnosis? Careful history of the injury, mechanism of injury. Clinical examination, the anatomical snuff box, pain in the anatomical snuff box. X-rays, bone scans, CTs, and MRIs. All very useful, but not always sure which one to do. So we've got this basic diagnostic pathway, starting with the history, the typical history, that anatomical snuff box pain, which we all know about. And then we do the full series of x-rays, being your AP, your lateral, your pronated and supinated obliques, and sometimes your clenched fist view, just to exclude your scapholunate ligament injuries. If no fracture is seen on this side, and it's a regular patient, then we put them into the cast for 10 days, still tender, we repeat x-rays. At this stage, hopefully the fracture is seen, and then we know our direction. We know what we're going to do, and we can plan our treatment accordingly. If there's still no fracture, then we go towards the side, the technetium bone scan or MRI. And mostly these days, it would be an MRI. But you always get this patient, a high-demand patient. What are we going to do? And really, the only thing to do is a MRI scan. It's being the most sensitive. Other than a bone scan, but these days not many people are doing that. So Duckworth looked at this problem of how we diagnose these fractures, and he looked at a couple of clinical parameters to try and see what is the most sensitive. Basically, the pain in the anatomical snuff box, pain on thumb to index finger pinch, tenderness on the scaphoid tubercle, pain with axial compression of the thumb, decreased range of motion of the thumb, and then he also looked at pain in different positions of the wrist in the anatomical snuff box. And he looked at it like this, acutely at 72 hours and then again at 10 days, and he divided into patients with no fracture and fractures. And they combined it with some demographic parameters, especially looking at male gender, sports injuries, and the mechanism of injury again. And I think the interesting thing here is patients who have no X-ray is normal, they do have tenderness in the anatomical snuff box, and if they are male and they fell during sports and they have pain with thumb index pinch, it is 74% chance that they actually have a fracture that we are not seeing. So those four things are actually very useful in terms of diagnosing. If there's no pain in the anatomical snuff box and nothing on the X-ray, there's almost no chance that they have a fracture. So just looking at the imaging again, we said a PA and a lateral X-ray. Remember to keep your elbow your elbow and your shoulder at 90 degrees to get your proper views. Your supinated and your pronated obliques. And they say that this should diagnose 97% of fractures. You can also do a clenched fist view to distract the fracture or to show you whether there might be a scapholunate injury which is maybe causing the pain. CT scan, to make the diagnosis, it may not be sensitive enough in your undisplaced fracture, which you're not seeing on an X-ray, but it is very useful to show your displacement and rotation. So for your surgical planning, it's very useful. MRI is the gold standard because it's very sensitive, but it may overdiagnose. And the typical situation is where patients present with an MRI that's got some edema in the scaphoid, and it's not clear if that is or isn't a fracture. But that's a pretty rare situation. We look at the fracture location, and this is going towards our classifications, and basically it's an anatomical classification: the waist, the proximal pole, the distal pole. Distal pole is pretty rare, often in children, and they heal very well. There's not too much distracting forces there. 70 to 80% of your patients are going to have waist fractures, and then you've got your rare, your less common, should I say, proximal third fractures. So Russe looked further at these, and he looked at the orientation of the fracture, and then Herbert had a more comprehensive classification. So just looking at that, 60% transverse fractures, most stable. Then you get your horizontal oblique, the next most common, also reasonably stable, but this vertical oblique pattern is particularly unstable, and you need to look for that. So Herbert sort of put that all together. He's divided it. He's got the chronic and the acute fractures. So your waist, your transverse waist, or your horizontal oblique waist fractures, your stable fracture, undisplaced, and then your tuberosity. And these immediately go into your stable side and get treated following the algorithm, which we'll look at now. So the important thing is to try and find these ones. So your unstable pattern is your oblique, that vertical oblique pattern. Displaced fractures, a millimeter, up to a millimeter is acceptable, more than a millimeter. I know it's very little and it's quite difficult to quantify a millimeter or a millimeter and a half, but essentially I say less than a millimeter or less is okay. And then your proximal third fractures all fall into this unstable group. Fracture dislocations, so your perilunate dislocations, and comminuted fractures. So when we're looking at treatment, each case obviously we need to look at on its merits, but we are guided by an algorithm. And really we look at this, what we've been looking at now, the position of the fracture and the displacement. So those A1 group, non-displaced fractures, scaphoid cast, control X-rays, watch it until it's united. Look for these signs, vacuolation, displacement, any signs of non-union, which immediately push up into this ORIF group. If your fracture is displaced, or it's that unstable pattern, so this proximal pole fracture, that vertical oblique, probably should go straight towards your ORIF group. We know that the proximal pole, we're going to use a dorsal approach, and the waist, the volar approach. So, what treatment have we got? Conservative treatment with a cast is obviously the mainstay, but here there are also some controversies. Is it above or below elbow? Do we include the thumb? And how long should we go for? I think it's clear now that a below elbow cast is acceptable. Pronation, supination doesn't seem to distract the fracture very much. Tim Davis has popularized this, leaving the thumb free in the cast. But I must say, I think that if you ask most people, they're much happier putting the thumb into the cast. And I do the same. And essentially, I think if you look at that Duckworth study, how much emphasis he placed on that thumb to index finger pinch, it means that and you get pain, it means that there's a significant amount of force across that fracture site. And I think that, maybe in a first world country where there's a lot of social support and the patients are told not to use that hand and they don't, you're safe not putting the thumb in a cast. But I feel it's much safer to keep that thumb immobilized out of harm's way where it actually can't be used. The duration, certainly, I think I tend to tell the patients we're going at least for 8 weeks and longer if it hasn't united yet. Obviously, you need to see fracture union is the obvious answer as to the duration, but I tend to go a little bit longer than shorter, and I tell the patients that right from the beginning. And the position of the wrist, essentially in neutral with slight dorsal, with sort of 20 to 30 degrees of dorsal extension, is a comfortable position for a patient. He's going to have this cast on for the next 2 months, so it needs to be comfortable. So, just looking at the indications, we've already sort of looked at this, greater than 1 millimeter of displacement. So anytime that, unless it's really very minimally displaced, you're being pushed into this displaced category. Looking at the scapholunate just gives you a better idea of whether there's any angulation. Proximal pole fractures, we've already said, a good indication for surgery. Perilunate dislocations, there's a lot of instability in the wrist, there's a lot of damage to the ligaments, there's no stability holding that scaphoid together. So these immediately would go into this surgical group. And this delayed and non-unions, these I'm going to discuss in the next talk. So just some examples there, proximal pole. Here's some signs of non-union in a patient treated in a cast. And there's your typical transscaphoid perilunate fracture. So it all seems so simple. But what would we do here? That is a clearly undisplaced scaphoid fracture. Of the waist, maybe tending towards proximal pole, but essentially a waist fracture. Put in a cast, 6 weeks, still looking good, but still fairly clear fracture line there. You might just worry a little bit, but no sign of AVN here. Then at 12 weeks, all of a sudden you get that X-ray. How to predict that, it's not very clear. There are some things that we'll look at just now. The question is, if you put a screw in that, would this not have happened? I think that's not very clear at this stage. The other thing is, if this was your fracture in your wrist, how would you like to be treated? Do you want to be in a cast for the next 8 weeks off work, or would you prefer to have a wrist that's fixed with immediate mobilization? So it's all pushing us in different directions, what can and what we can't do. So we know that surgery is a nice short period of immobilization, but we run the risks of surgery. Casting, inconvenient, but no operative risks. This is an important thing though. The union rate is actually similar in both groups if you have a well-performed cast or a well-performed operation. So you can't use that as a reason to push your patients in one direction. So looking at surgery, do we go volar or dorsal? And essentially, The volar side, there's less disruption of this blood supply, that we worry about, this dorsal blood supply. But we do run the risk of a hypertrophic scar along the volar side of the wrist. Increase your scapholunate angle by extending the wrist. Dorsally, you have a better scar and you have less disruption to your wrist joint when you're operating. Obviously, these days, this is all we use, cannulated compression screws. It's been a revelation in surgery. Headless screws were designed by Herbert. They're now a myriad of different types, Acute being very commonly used. But there's still papers being presented with K-wire fixation in the same way as distal radiuses. There are people who persevere with that. It can be very useful in very comminuted fractures, and where a screw just doesn't get purchased, or as you're fixing it, sort of the scaphoid starts falling apart. You can put multiple K-wires and hold your scaphoid. And there are papers that actually present good results with K-wires. And then lastly, the percutaneous, doing this whole operation percutaneously. So some examples. The important thing is to have your screw going down the middle of the scaphoid in both your AP and your lateral view. Must be middle. You want to get 2 millimeters from the proximal side and 2 millimeters from the distal side. So our percutaneous fixation is very useful, especially in these patients who want the operation quicker. They don't want to sit with a prolonged immobilization. In the patients who have been in a cast and are showing delayed union, we can go for a percutaneous fixation. We don't do much damage to the blood supply because we're not opening the whole scaphoid. And the dorsal versus volar approach is basically the same indications in terms of the site of the fracture. So there's a percutaneously fixed fracture, proximal sort of third. Okay. Just looking at the complications, these are all obviously generic complications, non-union, malunion. Avascular necrosis is difficult to decide or to quantify which patients are going to get avascular necrosis, other than to say that the more proximal the fracture, the higher the risk of avascular necrosis, and that's well sort of documented. Carpal instability and osteoarthritis. But some more specific ones, especially your posterior approach, EPL, EIP, and EDC. We go right between the third and fourth compartments. And if you don't put a drill guide over your drill, you can easily damage those tendons when you're drilling through. Same with the posterior interosseous nerve. Screw protrusion, screw too short. So screw protrusion, not necessarily because it's too long, but usually because it hasn't been put in deep enough. Often we try and look at the screw as it goes in, and it might look like it's just going under the cartilage, but it may not. When you get an X-ray post-operatively, it may still look proud on the bone. Screw too short. This is the same goes for any fixation. You know, if you don't bridge your fracture site enough, if you're putting in a nail and it's not going far enough across your femoral fracture, it's going to fail. And the same goes for here. It's been shown that the longer the screw, the better the stability within the scaphoid. So it mustn't be too long, but it mustn't be too short. And then KY breakage, the modern sets some of them have got a very, very thin K-wire. And it does make it very tricky when you're keeping your wrist flexed to keep your alignment of your drill on your K-wire correct. And sometimes as you're going through, that K-wire can break. And then you have to decide what to do, whether to remove it or to leave it. That's just a non-union, AVN, obviously. Your snack wrists, developing your arthritis there. So, what is the evidence at the moment? Essentially, there is evidence in favor of early surgical fixation, but it's not overwhelming. There are several papers, but essentially, you need to remember that a good scaphoid cast may be better than a badly done ORIF. So, it's not, if you can offer your patient an early surgical fixation percutaneously, and you can do it well, the patient will do well. But just beware. Don't rush in and try and fix everyone. A scaphoid cast is still a good option, and your union and the union rates essentially are equal. So my approach is to discuss with the patient, give them the option. Obviously, if there are any indications for surgery, we'll go straight for surgery. But if it's the undisplaced type of scaphoid, I start treatment in the thumb cast, and I'll review them at 10 days when you're doing another X-ray anyway, just to make sure that they haven't displaced. And then you can let them read around the topic and discuss with other people, and they can decide what they want. And many do opt to have an early fixation and mobilization. Most waist fractures I can treat percutaneously from the volar side. The proximal pole, because of that damage to the extensor tendons, I like to do a sort of a mini open there to keep those tendons protected. Just a few other tricks. You can use a needle as a guide for your K-wire. If you extend the wrist over a bolster and you get your assistant to hold the thumb and pull the thumb down, it pulls the trapezium backwards, and you can use the thumb as an alignment guide for your K-wire. Remember, you must try and be middle and middle. It's one of the most critical parts of your fixation. Use a shorter screw in doubt, but as long as possible. So this is also very tricky. Often when you measure it, you come out with a 30. And the books tell us, take 2 off here and 2 off for the other side, and then you'll put in a 26, and that's often too long. So 20, 22 in males, maybe 24s as well. But make sure it's not too short. Don't go and put in a 20 in a male, and you've just got a centimeter of screw on either side of the scaphoid and another centimeter beyond that. And then another thing, always believe your worst X-ray. So I know we were always taught the Radziowski views, and that's the one that you show your consultant in the post-intake wardrobe. But intraoperatively, believe your worst X-ray. If you see that screw may be protruding somewhere at the back, try and get another view. Most likely it is protruding. All right, thank you.